Welcome everyone to the Penn State College of Medicine COVID-19 Echo Series. We're delighted to have you join us for another session today. My name is Jackie Sable. I'm a member of the Echo team, and I'll be facilitating today's session. A few announcements before we begin. If you've not already done so, please put your name, email address, and affiliation in the chat box. Please stay muted unless you're speaking. You can use *6 on your phone or the microphone icon on the bottom left-hand corner of your Zoom screen to mute and unmute. You can also use the chat for communicating during the session. We know that question and answer time is important to you, and we try to categorize and address as many questions as possible, but if there are any unanswered questions or concerns, we will always follow up via email afterwards. If you have suggestions for future COVID-19 ECHO topics, please share them via the chat tool, or you can email us at echo@psu.edu. Please remember that if we're discussing cases, no personally identifiable information is allowed. We are recording these sessions, and we share all materials and recordings after each session. In the spirit of the all teach, all learn focus of ECHO, we will do a first name basis during our sessions. Our ECHO sessions always begin with a brief lecture, and they're followed by either a case discussion or a question and answer period. Today's session will include a brief lecture on COVID-19, top questions from the community by Drs. Robert Lennon, LJ Van Scoy, Bethany Snyder, and Aaron Miller. This will be followed by a question and answer period. During the lecture, please feel free to put your questions into the chat. We have 4 people who are presenting today, and we have a team of specialists from Penn State Health that join us. They will help to field questions, but please remember that this is all teach, all learn, so everyone you can submit both questions and answers. And with that, I'm going to turn things over to our presenters.
Okay. All right, well, thank you for inviting us today to talk about our messaging project. And here are some of the disclosures. Here's the experts. Okay, ooh, sorry, I'm having trouble with the remote control. All right, so the topic today is the top questions from the community. And I have been very fortunate to be part of an outstanding team that you see on the screen, Dr. Lennon, Bethany Snyder, Aaron Miller, and we have been working furiously for the last actually the last 50 days to collect some data about where the community members are with regards to COVID-19 related knowledge. And we're gonna share some of our preliminary results today. So we decided that we were really interested in understanding how people were receiving information in this pandemic setting. Ineffective messaging, as many of us already know, can be quite dangerous. So misinformation can result in things like failure for the public to comply with preventative measures as recommended by the CDC. There can be significant, some founded and some unfounded fears and anxieties and misconceptions about information as it's distributed and interpreted. And those misconceptions can lead to bad outcomes for patients, but also just for the country as a whole in preventable overuse of health services. And the sort of inappropriate messaging and response to it can lead our leaders to be misinformed or to drive inappropriate or inadequate decisions around policy. And so having effective messaging and understanding how the messaging is delivered in the community is super important, particularly in the setting of a pandemic. So here's our little sort of emotional, what's the word I'm looking for? I'm blanking on the word. Motivation, I should say, for us to make sure that everybody is understanding the reasons behind our work. Click. It's not clicking. There it goes. So our project started, I mentioned 50 days because just yesterday we submitted the paper from this study. So some of the data I'm going to keep rather general because it's still under review. But the thing about our experience was that we had to work really, really fast. And so on March 11th, we received funding to do a study on messaging. And we thought we would have a 1-year period that we could sort of get our work done slowly over the next couple of months. We were hoping for a 3-month start time. And then that turned to 3 hours and then, or 3 days and then 3 hours, basically. Later the same day that we received our funding, the World Health Organization declared a global pandemic. And soon after, the president declared the US national emergency. And so things, as we all know, were moving very quickly. We went into shutdown, the borders were closed. Our team actually has only met in person once. Which just seems crazy to me. But obviously, all of the data that we collected, it's important to understand the landscape of which the world or the community that we were surveying was under, and that knowledge was changing on a daily basis, and the experience was one of sort of a lot of anxiety. And so we sped up our timeline to try to learn how people were acquiring knowledge, how they were understanding knowledge, and we didn't even know what knowledge was at the time. And so one of the things that was a big challenge in this was to understand what is it exactly that is the truth, what is it that people need to know, and how do we measure that with any validity. And so we did our best to come up with a questionnaire using mixed methodology to appropriately analyze and assess in the community where people were with regards to COVID-related knowledge. So we focused in on knowledge, perceptions about COVID, their beliefs about the behaviors that were being recommended at the time social isolation was just starting, or I should say social distancing was just starting. Travel was being avoided or was being recommended to be avoided, but hadn't yet completely shut down. We were interested in learning about their beliefs about those recommendations and then their intent to follow those recommendations, because remember at the time, it wasn't quite a mandate. We also were interested in the concerns about not just COVID-19, but how do they perceive other infectious diseases like influenza? And then we were interested to learn how folks were getting their information. So we designed a survey quickly, but with rigor. We tried to have a nice balance of rigorous methodology and speed. So we included both quantitative, meaning numbers. So for those of you that aren't familiar with mixed methods, qualitative is more open-ended where people can sort of free text in their answers. And quantitative is more scales, you know, on a scale from 1 to 10, how do you feel about this, that, or the other? And in the context of knowledge, we designed a 15-item knowledge questionnaire based on the knowledge items of the day using true, false. But we also included a confidence rating in our knowledge exam. So we wanted not just to know if people could get the right answer, because in true false, you have a 50% chance, but we also asked them to indicate how confident they were so that we could really discriminate people that were just guessing from people that really knew what they were talking about, and also to understand the difference between the hard and the easy questions. We also looked at the beliefs, perceptions, and information sources. So with the help of the College of Medicine marketing team, we were able to deliver our survey rapidly within, I think, 18 days or something close to that, to 123,000 people, all of which were registered in a marketing database for Penn State Health System. And so the vast majority lived in central PA. And at the time, the context is very important in that we're not yet under stay-at-home orders. And what was surprising to us is that despite the fact that our survey takes about 20 minutes, maybe even 30 if you really get into the qualitative, and we had somewhere around 60 items, which is a very long survey, and we were concerned about that. The response was so amazing, so robust, people wanted to talk, that we actually broke our database. People started responding so quickly that the database couldn't keep up with it. And this is like a national database. So again, that's just to illustrate how quickly we got our responses. I think within the first 72 hours, we had 8,000 people complete our survey, but we analyzed about 6,000 of those in our actual data analysis, because 6,000 completed the entire survey. So I'm going to go through each of the findings here based on the construct. I'm going to share with you in general some of our findings about the knowledge domain, the beliefs, the recommendations, and so on and so forth. I'm going to share with you our quantitative data and then our qualitative data that helps to contextualize the numbers. So some of us are numbers people and some of us are words people. So we kind of put the numbers and the words together to contextualize the response. So what we found in our knowledge test, I'm pulling up the numbers here. In our knowledge test, we found actually, we were surprised. We thought the knowledge would be a lot lower than it was, but we actually had very good distribution, meaning that there was a nice bell curve of people that were getting them right and wrong. But overall, for the most part, the basic and total knowledge scores were quite high. And when I say high, I mean on the setting of about 75%. So 75% of the time when you ask the patients or the people in this survey whether they were getting the answers correct, they were getting the correct and they were confident about them, and that score ended up being 75%. This was lower for subgroups with lower educational status and non-minority racial status, so there was lower knowledge, but even so the knowledge was still pretty good. It was, around 70%, or I think a little bit lower for some of the lower education groups. But we were pretty pleased to see that the knowledge was, for the most part, higher than we had anticipated. So where there were knowledge gaps, though, were important gaps. So even though we did very well on the survey, there still were some really important misconceptions about COVID-19 that I think has room for improvement and in targeting various messaging. The number one thing that people misunderstood was that there were treatments for symptoms, meaning that you could treat COVID-19 with over-the-counter medications, or that you could provide symptomatic relief for viral symptoms. And so a lot of folks were not understanding that message. And in the qualitative data, which I'll show in a moment, we learned that people were actually seeking more information about how to treat the symptoms. What over-the-counter remedies should they use? What is it exactly that you can do to treat your cough or your cold or your sore throat? People wanted that information, and they didn't realize that those were available. We also found that people were not understanding the contagion of the disease. This was in particular with response to measles. And so the statement was that measles is more contagious than COVID, and that's a true statement, and a lot of folks didn't know that. And so thought that COVID-19 was the most widely spread contagious disease we've ever seen. And that, I think, drives a lot of fear and a lot of anxiety. And so that is a misconception that we could do a better job of getting through. The incubation period, this is not unusual that people weren't getting this right, because it's not entirely clear or known. But even so, the incubation period is something that people were very worried about, meaning how long does it take the virus to sort of simmer in the body before symptoms are apparent. And so information about the incubation period could be very helpful for the public. A lot of folks thought that all patients with COVID should be treated in an intensive care unit. And that actually is not, of course, true. Most patients have mild asymptomatic disease. If they do get into the hospital, they often do just fine in a hospital floor. And you'll see in some of our other data, the disease severity, like the seriousness of the disease, how sick they are, that's a big worry and anxiety. And folks need to know that, not everyone that gets this virus is going to die from it, like we're seeing in the media. Testing, where do I get a test? How do I get a test? That was very apparent. in the true and false, the question was about that everybody should get a test, and a lot of folks were getting that wrong, particularly in the early days. I think this is probably one of those questions that we might do a little bit better now that we have tests more available and it's a little less intense. But at the time of the survey, no one really knew how or where to get a test, and there was a lot of angst around that. And then another one that was like an honorable mention was whether or not steroids should be used for patients with respiratory failure. That was sort of a harder, more clinically based question for like healthcare providers, but even so, a lot of folks got it wrong, even healthcare providers. So from the qualitative data, we asked them about the information. We said, what exactly would you like to know that you don't already know? And the main theme was that there were unanswered questions about basic symptom management, basic principles of testing, and contagion. And we saw that not only in the quantitative, but also in the qualitative data. With regards to the CDC recommendations, we found that a lot of folks really did believe that the recommendations would help. It was high overall, and they intended to follow them. However, there was a disconnect. There was a disconnect between the folks that believed it would work and whether they were going to do it. So while there was strong belief that it would work, the intent to comply with the recommendations was 10% higher than the belief that it worked. So people were going to do it even though their belief wasn't as strong. And what essentially that is saying is that folks hear the messaging, and because there's sort of a government mandate, they intend to follow it. But not everyone was believing that they would work, but the majority was. So about 62% of the population felt that the CDC recommendations were going to work, but 10% more than that were actually following them. So the majority of people were believing it, but not everybody, or were following it, but not everybody necessarily was believing it. So our conclusions from those two constructs were that the messaging was actually pretty good. We had good knowledge, and we had strong sort of buy-in on the CDC recommendations. And so we asked them, what, if anything, would prevent you from maintaining the CDC recommendations or carrying them out? And overwhelmingly in the qualitative data, folks said, nothing, I'm gonna do it. And that again supported what we found in the survey items and the quantitative data, that there were very few barriers. The barriers that did exist were folks that needed to break the barriers in order to get essential supplies or seek medical care, things that are actually totally reasonable, but they perceive them as breaking barriers. And so overall, at least in the qualitative data, people felt that they were responding to the CDC recommendations. So then we started to ask questions about anxieties and concerns and how worried are you about the seriousness of these diseases. And we asked contextualized questions about COVID, influenza, measles, Ebola, and the most interesting comparisons were really comparing COVID and influenza, because as I'm sure many of you know, the diseases are actually quite similar. They're both viral, they cause viral pneumonias, they both cause acute respiratory distress syndrome. And so that comparison becomes very important. There were clearly very high levels of concern and anxiety around COVID-19. People were concerned if they were to be diagnosed with COVID-19, meaning that they had 93.5% of the patients said that they would be at least somewhat concerned, if not very concerned, should they get the diagnosis. But when you ask them that same question for influenza, that number dropped down to 70%. So 93% of the people were very concerned about COVID, but about the diagnosis of COVID, but only 70% for influenza. And while we would expect these two to be related, we actually found only a weak relationship between the likelihood of getting COVID and their concern about it. And what we concluded from there is that people were more aware, and this was true in the qualitative data I mentioned earlier, is that folks were most worried about the severity of the disease, more so than they were about the spread of the disease. I'm trying not to get click happy. I don't want it to over click, but it's not moving. Hang on. Click. Oh, I'm on the wrong screen. There it is. Okay. There it goes. All right. So related to worries, this was a really, really powerful question. We asked them qualitatively, what worries you the most about the COVID-19 pandemic? And the response is, sometimes when you ask these open-ended survey questions, you can, people will just write, I'm worried about everything, or I'm worried about getting sick, or, they don't really write a lot. These were long, robust, rich responses. People wanted to talk about what worried them. And we found 3 basic themes. There are many, many sub-themes to be explored further. But on our first preliminary analyses, we learned there were 3 major themes that popped out. One was medical. People were worried about becoming ill and contracting the virus themselves, or they were worried about their loved ones. And many of them were hearing the message that people are at high risk. That there are high-risk individuals for this virus. And folks would say things like, I'm worried about my 90-year-old grandmother because I know she's in high risk. So it was more that folks were worried about the high-risk people than they were worried about themselves, which is reassuring because that was sort of what, some of the messaging that we're trying to get out there. We also learned that epidemiologic and public health issues were really big. People were really concerned about the lack of perceived concern of others. They were worried about, the cartoon that we had earlier about the spring breakers. They were actually mentioned in one of the qualitative quotes. They were worried that people weren't taking it seriously. They were worried about the impact this would have on resources and healthcare providers and rationing and all of the issues that we're seeing in the media. And so I would say equally as prevalent in the patient medical related was the impact that this has on our public health and our medical infrastructure. And then the final theme was in this area was that the economic and societal disruptions were of major concern to folks as well. Small businesses, layoffs, all of those issues, even in the very early, remember, this was the early phase. This was even before the stay-at-home had taken place. So people were already forward thinking about the impact this would have on the economy and on society, and that was a major concern. For information sources, we were happy to learn that the #1 source of information was the CDC website. 40% of folks indicated that their #1 source, when we had them pick one, the options were things like TV news, we had all the social medias, internet news, radio, emails, everything. And so the #1 pick was CDC. And the #2 pick was TV news. And then we gave them the option to pick other sources. So although you may pick your #1, what else are you using? And when we asked them what else, we found that they were using TV news and CDC, of course, but also other internet news sites and Facebook. Facebook was about 20% of folks were using Facebook as a source of news. Family and friends was also very high at 20%. And surprisingly, considering that Twitter is one of the main ways that the president and the government has been communicating in the last several years, that the only 4% of our population was using Twitter as a news source at all. Not only their number, it wasn't really being used as a primary news source, but it was even very low as a secondary news source. And then when we asked folks if they felt like they had received enough info, the majority of people did feel like they had enough information. I need to get the data number in front of me. Sorry, we didn't put these on the slides because the paper is still under review. But the majority of people did feel that the information that they were getting was adequate and that they had everything that they needed, or that they had most of what they needed. And that was about 70% of people. But there was about 40% of people that were worried about misinformation. So we asked a yes or no question. Are you worried that you're getting misinformation? And 40% of the people said, yes, I am in fact worried. When we asked them this qualitatively, we asked them, how did you feel about the way the information was delivered? And this to me was the most exciting theme, not exciting, but the most interesting theme, perhaps the most depressing theme, but that there was significant distrust in information provided by the federal government. There was concern about politicizing of the pandemic response, and there was a lot of comments about not wanting to listen to the executive branch, even though folks were trusting and getting information from the public health government websites, CDC, World Health, NIH, et cetera. There were a lot of qualitative consults about the messaging they were seeing, qualitative comments, I'm sorry, about the messaging they were seeing in the news media, and that they were distrustful of information provided by the executive branch of the federal government. They also were a lot of negative and unsettled perceptions about the media coverage, and that it was very stressful and very worrisome to them about, not so much about COVID, but they were stressed by what they were seeing on TV about this mixed messaging. So it wasn't that they were necessarily in this theme, they weren't worried about the disease, but they were worried about the information disease or the information dissemination. And so that shows that we have work to do as far as figuring out ways to reduce mixed information and increase the trust. And so those were the big, broad scopes of what we learned from our community here in central Pennsylvania. Remember, this was a survey of about 6,000 people in central Pennsylvania, but it really didn't get to the point where we can generalize to minority populations. We had, I think, only 8% of minority voices were heard. And so, we say in the data, knowledge is high, but knowledge is high in our groups. And there's a lot of clues suggesting that knowledge is not so high in other groups. And so to do this, or to study this and evaluate this, we have created a social media survey and an online survey that will be deployed worldwide so that we can get the voices of some of the underrepresented individuals that are not in our local PA sample. We've translated our survey into 23 languages, and our hope is that we can get many tens of thousands, if not more, responses. And in order to do that, we're actually going to ask everyone on this call to help us by taking the survey. The survey is available on social media, and we'll be providing the link, and help us to spread the word, particularly in your communities or in minority-based communities, so that we can make sure that we're capturing those very important voices. We have a video about the global survey, which I'd like to share. Uh-oh, can you not hear it? Oh, you hear it? Oh, I don't hear it. Oh, I see people shaking their head. No, they don't hear it. Uh-oh, but Erica, you hear it.
So I'm just gonna unmute myself.
Yeah.
And maybe, there we go. Try it now.
Well, you try it. You go ahead. I think you're.
The COVID pandemic continues to spread around the world. It affects each of us in a different way. While we wait for a vaccine and a cure, our best defense against the virus is information about how to stay safe and prevent further spreading. Researchers at the Penn State College of Medicine are leading the effort to gather information on how people around the world understand COVID-19. Share your story in your language. Please take the survey and help us improve COVID information.
So here's the link. As of today, about an hour ago, when we looked at our social media responses, we've gotten over 11,000 responses, covering all 50 states in Pennsylvania and 23 countries. Is that, I'm not, did we get all 23 countries, Rob? Or is that just saying that it's available in 23 languages? We may have already gotten all 23.
It is available in 23 languages. We've also had responses from 23 countries.
Oh, okay, good.
50 states and the District of Columbia.
Yeah. And so with that, I'm going to stop the presentation, the didactic portion, and take questions about the information, what we learned, whatever it is that this group would like to chat about. And I don't know, Rob, do you want me to toss it over to you? Do you have any comments to add?
Well, I think the key is what we talked about towards the end about a limit of generalizability. As we're seeing the great disparity in health outcomes from minority and socioeconomic groups that are less advantaged, our fear is that governments, agencies would use our data to say, look, about 75% of folks are doing great with messaging, and say that means we're doing good and call it a day. And the danger is that it's not 75%, it's more like 90% of the high socioeconomic groups, and it's well below 30% in some of the lower groups. So those voices that aren't heard, until they're heard, it's difficult to compel agencies to change their messaging. So we're trying to do a lot of community outreach with that. George Fernandez of the Latino Connection has been instrumental in that, and connecting us to minority outreach groups across the state. And Chime has been a great partner to try and get this message out to communities around the world. But we definitely need your help. And the qualitative data we're getting from those groups, not surprisingly, is quite different from what we're getting from upper middle class Caucasians in suburban areas. We look at the CDC website and it has great information, and you can click a button that translates into many languages. The problem is there's about 20% of our population that never goes to the CDC website. They get their information from different places, and until we know that, we can't combat it. So some of the misinformation that's going out on those networks that aren't even visible to us is impossible to combat if we don't know where they are. So that's why we're so desperate for your help. And we're happy to take any questions about the Pennsylvania survey and the data that we collected.
Would you mind, not everyone can see the chat, would you mind going over the 2 questions that you answered via the chat?
Sure. We had a question about what the age range was. The age range was, it was open only to adults, and the range was about 18 to 95. Our average age was older, it was about 62 if I recall correctly. And the way we reach these folks is through a marketing list that's maintained by Penn State Health Marketing Group. The marketing list is primarily patients enrolled, but it does include prospective patients. All of these people are folks who have signed up and they check the box that says, yes, I would love to receive more information. So we emailed that group, and the responses are from that group. We can't technically say it's Central Pennsylvania only, because the group, some people live outside of Central Pennsylvania, but from our understanding of how they do the data, it's roughly 95% of the folks are in the 6 counties that make up Central PA.
Thank you. And there's another question. Did you ask if people were using their state department website?
Sorry. Yeah, we actually didn't ask that explicitly about state level, because at the time we were sort of trying to hone questions. But what was very interesting qualitatively, and one of the things that we want to explore further, is that there was a lot of distrust of the executive branch, the federal messaging, and that was often contrasted with trust in the state level messaging. And so folks were, from the qualitative responses, certainly more trustful, some still distrustful, but most trustful of the state level information. If you do like a word search, Dr. Fauci, Dr. Levine, those names, Governor Cuomo, those names come up frequently as being trusted sources. And I thought that, we don't yet have a robust enough analysis to really talk about the prevalence of those things. But it certainly seems from the sample that we've reviewed thus far is that the state level is really the most effective conduit, and we should be focusing efforts in that way.
And in the survey that's currently underway, we do break it down into local level. That was something the Europeans wanted. They have a much stricter hierarchy of how their health systems are, so they wanted the state level in. We felt that we couldn't go below state because across nations it's very difficult to distinguish that level. In some countries it just doesn't make sense to separate into the local level, so we left it at national and local, which can be interpreted more as regional, and then we left it to the qualitative responses to parse that further. I'm actually quite hopeful that also in the qualitative data we will get from particularly the more socially oriented minority communities, the free text that says community leadership, so that going forward, instead of just pushing things out on a CDC website, we say part of the information is direct engagement with these community leaders, not simply sending them the information, but ensuring that they believe it. Because if the community leader that's actually listened to doesn't believe it, they will never push it forward. And that, in my opinion, is incumbent upon us as health professionals to get to that level. That's what communication really is. And that's something Oprah Winfrey commented on in her podcast last week, talking about the racial disparity of this. She said, it's important to understand that communication, pushing information out, is not the same as connection, which is the more holistic interpretation of communication, of a mutual understanding. I think she nailed it. And I think it's tempting for us to say we put the information out, that's good enough. And it's not good enough. Putting the information out is insufficient. We have to put it out where people want to get it, in a way they are able to understand it, and in a way that their leaders believe it, so that these things are followed.
This is Greg. Can I ask a question? You mentioned that you didn't sort the data by any more local than at the state level. Is that what you said?
All of the data, this data was in the state of Pennsylvania.
And my question has to do with rurality and zip code, and the fact that there may have been trust among the people responding in the state government and mistrust perhaps at the national level in certain locations, and that perhaps rural individuals, people who lived in rural locales, it may be flipped in regard. And so, could you comment on that, please?
Yeah, so we think you're exactly right. And so that reason, the survey that we're underway now, we're getting the first 3 digits of the zip code precisely so that we can look at that. We couldn't get all 5 digits, which would be a richer data set, because we couldn't get it through the IRB in a fast enough way to launch it. But with the first 3, we can actually get roughly to the county level, and we're going to be able to look at that. And the neat thing about that is we're partnering with a political analyst group to say, okay, we can give you this health data by first 3 of the zip code. We want you to look at the commentary by political leaders out of those same first 3 zip codes. And they can do it, it won't quite overlap, but they can do it by down to the district level of state representatives and state senators. So we'll really be able to see, what does it mean to have a local politician or a state politician or the national politician say words? If we get a rich enough data set, we've talked to some other folks about getting natural language searches in so that we can search, here's a person that said this tweet at this time, or put this out in this news thing. Let's search for that phrase in the free text areas, and we can see where people are listening. So we can see who is listening to what, how does this permeate? And if we get enough responses, we'll be able to correlate that. We can do the same thing with what I call the Facebook effect. And not to pick on Facebook, but just social media in general, we can say, all right, if nobody puts down, all the people that don't mark Facebook, what is their knowledge and fear? And now let's look at, if all you do is check Facebook at all, how is it different? To look at, where is the real influence of this information coming from? The people that analyze news are very interested in this. We talked to a large company's tech analyst firm that does data analytics for news, and their comment was, the last time Americans changed the way they consume news was after 9/11. And we believe that COVID will have the same effect, but nobody knows how it's going to do it. And we need to know this. And I said, well, I'm about to ask everyone in the world, what do you want to know? And they helped us craft the question to say, well, we need to know, are you changing the way you do your news? How do you do this? And they were the ones who really pushed for, we have to know where they live. Can we get the zip code data in? So I think your point is spot on. And I think we'll see that difference in rurality and urban. I think we'll see it across racial lines. I think we'll see it across state lines and economic lines. And really understanding that is the key to putting the puzzle together to get information to everyone where they want to get it.
Thank you for that. Are there other questions or comments? And you can feel free to unmute your microphone or put them right into the chat.
Hi, yes, my name is Michelle. For if this is the same survey that you plan to use for international respondents as well, is there going to be a space for people to choose that they receive news from WhatsApp as well?
Yes, and I'm so glad you brought that up. So one of the greatest challenges we had was saying, we're asking these questions in English to Americans. How does that translate to other countries? So for example, many parts of the world have no idea what CDC is. And many parts of the world don't know what World Health Organization is or how, and you're exactly right. For at least the Southern Hemisphere, WhatsApp is how communication is done. So we include WhatsApp, and we also include a free text area. So if we missed it in the drop down, you can free text what you want. And the neat thing about our survey thing is it automatically pops up a word cloud of where people get their news. And it's been fascinating to look at it and see, wow, I'd never heard that existed. But in this part of the world, this is where they get their news. So yes, definitely hopeful to get that in WhatsApp.
I have a question for Dr. Lennon. How often per day do you check the website for the word clouds?
In the first week, I didn't sleep very much, and now I'm making an effort to sleep more. So I limited myself to once a day.
Nice.
Other questions for the team?
One thing I want to add on is that what we're planning on doing next, in addition to the social media survey, is a qualitative phone interview follow-up to sort of get at some of the things that we found in our mixed methods data thus far, to sort of go after the explanation. So we do have from our Pennsylvania survey phone numbers that we can reach people. And we did ask them a question about whether they'd agree to a phone interview for follow-up. And so one of the things that we're looking at is which groups should we call? And I think the idea of rurality versus urban, if we can sort of figure out ways to parse that in what we have, we're going to be looking at folks with lower educational attainment and higher educational attainment. While we didn't have a big representation of minorities, we certainly will be reaching out to them to try to understand better their perspectives and learn more about their community. And so we're going to be sort of picking representative groups across the spectrum to get even more qualitative data so that we can better contextualize what we've learned in this first sort of overview. And obviously our team met 50 days ago. We didn't know each other 50 days ago. So there's a lot still for us to explore in this data.
And by social media survey, you really mean like a Facebook, right? Because
the global, yeah.
Because I'm a heavy Facebook influencer, but you have to acknowledge that people on Facebook are for the most part over the age of 35. Yep. And so there's like a real big gap there in regards to their demographics. And so how are you going to keep that into account? Not wanting to skew the data.
So that's an extremely good question, and definitively a challenge on going through an online survey. So with an online survey, we cannot get at true prevalence. That's not possible. We don't have a true denominator. So it is Facebook, but it's actually any electronic media. So that includes cell phone to cell phone link switches. And for the younger crowd, we're working with some folks through Chime to go to things like TikTok, Instagram, and a whole bunch of things that as an older guy I'd never heard of before. And they told me that I was not just out of date, but over 2 generations out of date, and that no, the younger kids don't know what that is anymore. So the folks that do understand that are having a better sense in trying to reach out. So in particular, D-Nice has been doing some really interesting COVID parties online, doing rap battles online. I think the last one on Monday night had 500,000 people worldwide signed in to do it. So they're trying to reach out through that venue into the community, into the communities of younger folks that aren't on Facebook, that aren't in more traditional demographics. We've definitely seen that skew as we do media pushes. The media push that goes out through LinkedIn generates responses of higher educated, wealthier folks. Things that go out through Facebook, slightly lower. Things that go out through radio or other things, slightly lower and slightly different. The hope is to hit all of them. Our funding for this is exactly $0. So it's pretty challenging to do buys. Some very generous folks. Chime donated money explicitly just to do some media outreach. The marketing department at Penn State very generously said, we will use some of our budget to do this. And influencers like yourself have stepped up and said, hey, we think this is really important. We will do it. So Solomon Jones is a radio personality in Philadelphia and freelances for the Philadelphia Inquirer. He was gracious enough to interview us on his radio program just to talk out and reach to other communities.
When do you think you'll have the worldwide survey results, or when do you hope to at least publish your initial findings?
We will pull what I call the national data set at the end of April, and we have international responses in it, but by then I think we will have sufficient demographic distribution within the United States to make definitive generalizable statements about where groups are. We will continue the international push and leave the survey open at least through May, and are working with some folks that work for the World National Congress of Family Medicine Physicians and the Besroor Institute in Toronto, for them to join and seek additional funding through the Gates Foundation explicitly for international outreach. Whether that happens or not, we don't know. But our thought is we can keep the survey open. We can pick which data sets to look at. So as these events occur, we can say what happened before this event is different from what happened after the event. So in May, many parts of this country will have started reopening. That's gonna change the information data. We'll keep it open, but be able to compare it and say before and after the opening, this is what it looked like.
Yeah.
So the first national data set, hopefully we'll pull it essentially May 1st. We'll have preliminary analysis within a week or two. The deeper analysis will literally take years and years. Once we have the data set cleaned and usable, we will publish it so it's free for researchers around the world to look at. Particularly the qualitative components that are in other languages, that will take teams of cultural anthropologists to look at for years. It's not something we can do alone. And then we'll do the same thing as we get better international responses. I'm guessing the end of May will be a big poll. And depending on the funding that comes through and how COVID is being dealt with worldwide, we can continue the survey even longer just to watch the changes over time. Right now, we're still in the isolation containment phase. The next big phase will be reopening. There will be a big phase after that on first vaccines, and then there will be a big phase after that in the event there's any effort at cure. Every one of those things may give us better information on how to reach folks. So the longer we can keep it open, the better and more robust the data set we can get.
And a lot of that, I think, that question that I mentioned in the qualitative data was what worries you the most. You can imagine that if we ask that question today, the answers would be about reopening and lessening the social distancing and the way with which that is going to happen. So that would be really different than the worries that we had just 3-4 weeks ago when we did the survey. So I totally agree with Rob, is that, even if the knowledge questions, right, the knowledge items become less relevant or change, the answers already we had a couple answers change. Like one of the questions was about, should you wear a face mask in public? Well, at the time that we did our survey, the answer was no, and now the answer is yes. And so obviously the facts and the knowledge is changing, which makes this really challenging. But the beauty of the qualitative incorporation here is that the qualitative data won't change, right? Or it'll reflect the moment in time. So it's extremely exciting to think about. I'm getting palpitations just thinking of all the analyses that we're going to be doing. And we need a team of about 30,000 people to cover all the data.
What about a question regarding the people that you sent the survey out to are all able to fill the survey out online, but what about people who don't have that ability to fill the survey out, because they may be getting their information through community leaders and through community health workers and things like people like that?
So this is the fundamental problem with doing online research and doing this electronic research is the baseline assumption of wealth and technology access. We have no funding, which means this is all we have. However, we're getting enough traction with this that we're starting to build a collaboration with the Medical College of Wisconsin. And one of the things that we're hoping to do is go after explicit funding to do electronic versions and also paper versions with people out in the community to see if they are similar. And one of the thoughts is, it may be that in some groups, that distinction of poverty and not is less important than just the social group. And if that's true, then the electronic survey may be sufficient. We don't know that though, and we need to find out without question. And some obvious things that come up are, what about homeless people that don't have anything? Well, they're a massively high-risk group, and we can't talk to them. What about prisoners, particularly prisoners in other countries where literally there not only is no access, there's no access at all to anything. Unfortunately, just with the limitations we have, we can't reach them now. But without question, the hope is to use this to build funding to go in and reach those folks. This is the first step to say just the CDC isn't enough. The next step is pushing to make these changes, and the step after that is, how do we get even further and deeper into the community? That's a great point.
And phone interviews, collecting the data by phone is something we've been talking about as well, because of the issues with social distancing right now. Even if we wanted to go out in the communities, we can't. So we had talked about paper versions a couple days ago, actually, and as of right now, obviously, once reopening happens, we'll be able to relook at the way that we might be able to get out to community leaders and leverage trusted networks to help us collect data. But for right now, obviously, with social distancing, we're stuck with the online platforms.
LJ, if I can interrupt real quick, I don't want to lose this question. I'm not sure if it was addressed or not, but Lex was asking about the results of the Penn State survey. Will they be published?
Yeah, so the results of the Penn State survey. So the Penn State survey went out to 8,800 Penn State health employees. So not just healthcare providers, but anyone that is employed at Penn State Health. And we received, I think, only 250 responses, which was quite a low response rate. We haven't yet analyzed that data. We intend to, because that was one of the, when Rob says we didn't have any funding, he means for the social media global survey. For the Pennsylvania survey, we had funding to do the healthcare provider survey, but the response was less robust, which is not at all surprising when you think about how busy everybody was at that time. We were all transitioning, the day after we started, it became a global pandemic, and then the stay-at-home order happened. And so everybody just sort of left, and there was chaos, right? I mean, for those of us that are healthcare providers, we know how busy everyone was. I don't think anyone had the opportunity to take a 20 to 30 minute survey, and appropriately, we didn't want to disseminate it too much and nag people too much because they were busy doing other things. So we weren't able to really capture as robust a response in that survey. But 250 responses is still pretty darn good, and we do intend to analyze and take a look. It just hasn't hit the top of our priority list yet.
And there's another question in the chat about distribution mechanisms.
Mm-hmm.
And Rob just answered it, so thank you.
If we print out this survey and have people complete it who do not use social media or computers, can we mail the completed survey to you? Where to mail? Yes, please do. we don't have resources to analyze them, I can promise you. We can analyze the qualitative in particular. We can incorporate qualitative responses into our data set from paper versions. We also might be able to manually enter them into REDCap ourselves, depending on how many we were to get. So I would say send them along, and if we can use them, we absolutely will. Particularly, you know, we want underrepresented groups. I don't know if folks who are disabled are highly at risk, marginalized, disenfranchised, and experience quite a bit of anxiety. Any thought as how to reach them, as those disabilities may limit access to information?
I think the best way for that, again, since we don't have funding to specifically target it, is to try and reach out through groups like this with folks who are engaged to say, if you have access to these communities, please let them know to try and get the information out. I wish we had the funding to send people into these places, especially, you know, group homes, and do it in person. We just don't have the funding to do it. Down the road, if we are able to get funding to keep doing this and do it in a rigorous way, over the years it will take to truly validate these surveys, we'll be able to target very specific groups and over that time build on all the subgroups that are marginalized to bring in everyone eventually into how we get information out.
Are there other questions or comments? We have a few minutes left. Well, if we don't have other questions, I'll go into our wrap-up announcements, but I would encourage you to use the extra 4 minutes in your day to either complete the survey or start sharing it with your colleagues and social networks. So let me pull up our quick announcements. Just a reminder that you can collect CMEs for today. The survey is always sent, and you can use the same survey for every session that you attend, and just use the same link. All materials will be shared via email. Please consider submitting cases for future talks, and we hope you'll join us for our next session that's scheduled for next Tuesday, the 28th at 9 a.m. And Dr. Katie Shedlock will discuss the impact of COVID-19 on our children. I'm going to do one more quick glance to see if there are any questions that have come in. A couple of contacts, I think, for you, Rob and LJ.
And for the, Jackie, for the YouTube posting, I think definitely feel free to put our contact information. I don't know, Rob, if you can put my contact information in there anyway.
Without question, it sounds kind of cheesy to say it, but I started doing medical research in 1988 at Mayo Clinic, and this, without question, will be the most important thing I ever do. There's no question at all that this global survey, the responses, the ability to outreach to more people across the country, this is the most important thing I will ever do. So you can call me day or night, or text me or email me. I will get back to you. I may not answer the phone immediately. I'm actually an introverted researcher, and this kind of outreach is new and overwhelming to me, but I promise you I will get back to you, and I am extremely, extremely grateful for your participation. Thank you.